Welcome back to the Deep Dive. If you're gearing up for clinicals or maybe just staring down that next pharm exam, you know this stuff is, well, it's a fundamental. Managing fluids and electrolytes, it's got to be the absolute cornerstone of patient care.
It really is. And that's exactly what we're tackling today. We're doing a focused, high-yield deep dive right into Chapter 30 of Lilley's Pharmacology for Canadian Healthcare Practice.
Okay.
Our goal, simple, break down the core physiology, get clear on the main drug categories, crystalloids, colloids, blood products, and really focus on the safety stuff. Especially around potassium and sodium, those are high alert.
High alert for sure. This should be a good shortcut through a pretty dense chapter.
Exactly.
All right, so let's start where the fluid actually lives. The source says about, 60% of an adult's weight is water. Total body water, DBW.
Yep, around 60%. And the key thing isn't just the amount, it's where it is. It's compartmentalized.
Right, not just one big pool.
Not at all. Think of it like this. 2/3 of that water, it's locked inside your cells. That's the intracellular fluid, ICF.
Okay, inside the cells.
The other third is outside the cells, extracellular fluid, ECF. And even that's split.
Okay.
Part of it's in your blood vessels, that's the intravascular fluid, or plasma. And the rest is surrounding the cells, the interstitial fluid, ISF.
Gotcha. Plasma and the fluid between cells.
Exactly. And when everything's in balance, all these compartments have the right amount. That perfect state is called euvolemia.
Euvolemia, okay. But this fluid isn't static, right? It's moving all the time.
Constantly. And that movement, it comes down to pressure. A push and a pull system. If you get that, you understand why fluids shift, why edema happens, why dehydration looks the way it does.
So what's doing the pushing and pulling?
Well, the main pulling force is colloid oncotic pressure, cafeteria. It's mostly generated by big protein molecules in the blood, mainly albumin.
Albumin, right? The big one.
Yeah, it makes up like 80% of it. These proteins are too large to just leak out of the blood vessels easily, so they act like magnets, pulling water into the vessels.
Okay, pulling water in.
Yeah.
What's the normal pressure value for that pull?
The source gives us a number, 24 millimeters of mercury. That's the normal COP.
24. So, just thinking ahead, if someone's malnourished or maybe has liver problems and isn't making enough albumin, what happens then?
Good question. You lose that pulling power, the COP drops.
And the fluid.
It starts to leak out. Because there's an opposing force, the hydrostatic pressure, HP, that's the pressure pushing fluid out of the vessels into the interstitial space. Normally it's lower, around 17 millimeter Hg.
So if COP drops below HP?
The pushing wins. Fluid leaves the vessels, goes into the tissues, and that's when you start seeing edema, swelling.
Okay, that makes sense. Pressures control the location. Which leads us straight into tonicity when we talk about IV fluids. This is where it gets really interesting and kind of critical for IV therapy.
Absolutely critical. Tonicity is all about the concentration of the IV fluid compared to the concentration inside the patient's cells, especially red blood cells.
And the classic way to picture this is what happens to a red blood cell dropped into different solutions.
Exactly. It's the best visual. So if you use an isotonic solution, like 0.9% normal saline.
Standard saline.
Right. Its concentration, its osmotic pressure basically matches the inside of the cell. So there's no major shift of water. The cell stays the same size. Happy cell.
Okay. Isotonic, no change. What about hypotonic? Like half normal saline, 0.45% ACL.
Hypo means lower concentration outside the cell compared to inside. Water follows solute, right? So water rushes into the cell to try and balance things out.
Rushes in, so the cell swells up.
It swells, and if it's too much, it can actually burst. That's hemolysis, a really dangerous outcome.
Okay, definitely want to avoid that. And the opposite, hypertonic, like that strong 3% saline.
Hyper means higher concentration outside the cell. So now the water gets pulled out of the cell, trying to dilute the stronger solution outside.
Pulling water out. So the cell shrinks.
Yep. The cell crenates, or shrinks. Also not good for cell function.
So choosing the right IV fluid, isotonic, hypotonic, hypertonic, depends entirely on what kind of dehydration the patient has.
Precisely. The source text actually lays out 3 main types, and the treatment is different for each because the underlying problem is different.
Okay, let's quickly nail those down. What are they?
First, hypertonic dehydration. This is when you lose more water than sodium. Think high fever, lots of sweating, maybe diabetes insipidus. The blood gets concentrated.
So you need to replace the water mainly.
Right. You'd likely use a hypotonic solution to get water back into the cells and dilute the ECF.
Makes sense.
What's next? Hypotonic dehydration. Here, you lose more sodium than water. Maybe from like kidney problems where you can't conserve sodium, or excessive sweating replaced only with plain water.
So the blood is too dilute.
Yeah, and water might even shift into cells inappropriately. So here, you might need a hypertonic solution carefully administered to pull water back out of the cells and raise the sodium level.
Okay, and the last one.
Isotonic dehydration is probably the most common. You lose water and sodium in roughly equal amounts. Classic example is vomiting and diarrhea.
So you just volume down.
Exactly. You're euvolemic in terms of concentration, just depleted overall. So the goal is just volume replacement, usually with an isotonic fluid like normal saline or lactated ringers.
Got it. That distinction is really important for picking the right tool. So for that common isotonic dehydration, you mentioned crystalloids. Let's dig into those first.
Okay, crystalloids are the workhorses. They're solutions of water with electrolytes like sodium, sometimes potassium, chloride, lactate. Think normal saline, lactated ringers.
And they pass easily through membranes.
Yep. They diffuse pretty freely between the intravascular and interstitial spaces because they're small molecules. They supply water and sodium, great for maintenance fluids, replacing insensible losses, managing shock initially.
But you said earlier they can cause edema. If they're like normal body fluid, why do they leak out so much?
That's the key trade-off, because they don't contain those large protein molecules like albumin.
Right, no colloids in them.
Exactly. So when you infuse a lot of crystalloid, you actually dilute the patient's own plasma proteins. This lowers the natural colloid oncotic pressure, that pulling force.
Ah, I see. Less pull means more leak.
Precisely. The fluid doesn't stay in the vessels as well. It leaks out into the interstitial space. That's why you often need to give large volumes of crystalloids, like 3 liters for every 1 liter of blood lost, and why peripheral and even pulmonary edema are significant risks. Their effect is also relatively short-lived.
Okay, so they hydrate everywhere, maybe too much everywhere, which perfectly sets the stage for the next category. Colloids. These are different, right? They have a big molecule.
Yes, exactly. Colloids contain large protein or starch molecules that don't easily pass out of the blood vessels. Think albumin itself, or synthetics like dextran or head of starch.
So they stay in the plasma.
They stay put in the intravascular space, and because they're large molecules, they exert that colloid oncotic pressure. They actively pull fluid from the interstitial space back into the blood vessels.
So they're plasma expanders.
That's the term, yeah. They're much more efficient at increasing blood volume than crystalloids, volume for volume, and the effect lasts longer.
Sounds great, but there's always a catch, right? What are the downsides?
Several important ones. First, they're way more expensive than crystalloids. Second, they don't carry oxygen.
Okay.
And because they expand volume so effectively, they can cause circulatory overload, especially in patients with heart failure or kidney problems. The source specifically warns against using albumin in heart failure, severe anemia, or renal insufficiency for this reason.
That fluid shift could overwhelm the heart.
Definitely. And another risk, they can dilute the patient's own clotting factors by pulling in so much fluid, which can mess with coagulation and potentially increase bleeding risk. Dextran especially has effects on platelet function.
So more potent volume expansion, but higher cost and some serious specific risks.
Okay. That leads us to the third category, which is kind of biological. Blood products.
Right. And these are unique. They're the only fluids we can give that actually carry oxygen.
Yeah.
Because they contain hemoglobin. Ah, the oxygen carriers. Critical difference.
Huge difference. They're also potent plasma expanders. The textbook indicates they're typically used for major blood loss, like losing more than 25% of total blood volume.
What are the main types we use?
Primarily packed red blood cells, PRBCs. These are mostly red cells used specifically to increase oxygen carrying capacity when someone's anemic or has lost a lot of blood. Less volume than whole blood, so less risk of fluid overload.
Okay, PRBCs for oxygen. What else?
Fresh frozen plasma, FFP. This is used to replace clotting factors if someone has a deficiency, like in liver disease or massive transfusion situations.
Gotcha. Now, you mentioned safety earlier. Is there a supercritical safety point with blood products?
Absolutely non-negotiable. Blood products can only be administered with one specific IV fluid, 0.9% normal saline.
Only saline. Why? What happens if you use something else, like D5W?
D5W, that's 5% dextrose in water, is hypotonic relative to red cells once the dextrose gets metabolized. If you mix blood with D5W, the red blood cells will swell and burst hemolysis. It's a catastrophic error.
Wow. Okay, saline only. Burn that into memory.
Definitely.
All right, let's shift gears now to the electrolytes themselves, the real high alert players in this chapter. Starting with potassium. K plus N.
Yeah, potassium is huge. It's the main intracellular cation. Most of it lives inside the cells. The amount in the plasma is actually tiny, but that narrow range, 3.5 to 5.0 millimoles per liter, is incredibly critical.
Why so critical? What does potassium do?
It's essential for, well, everything electric in the body. Nerve impulse transmission, muscle contraction, including the heart muscle, and it plays a massive role in the heart's pacemaker function and rhythm.
So problems with potassium mean problems with muscles and the heart.
Big time. If potassium gets too high, hyperkalemia, above 5.5 millimole, you see muscle weakness, potentially paralysis, and really dangerous cardiac effects like ventricular fibrillation or even cardiac arrest.
What causes hyperkalemia?
Kidney failure is a big one because the kidneys normally excrete potassium. Also, certain drugs like ACE inhibitors or potassium-sparing diuretics, major trauma or burns that release potassium from damaged cells.
Okay. And the flip side, low potassium hypokalemia, below 3.5.
This is actually more common, often from losses. Think diarrhea, vomiting, or using certain diuretics like loop diuretics that make you waste potassium.
And the symptoms. The book mentions early and late signs.
Right. Early on with mild hypokalemia, you might see fatigue, muscle weakness, maybe some nausea. But if it gets severe, you're looking at serious cardiac dysrhythmias, confusion, and even paralytic ileus where the bowel stops moving.
So treating potassium imbalances, especially giving IV potassium for hypokalemia, must be done super carefully.
Incredibly carefully. 5-E potassium is absolutely a high alert medication. The #1 rule. It must always be diluted. Never, ever give concentrated potassium IV push or bolus that can be lethal.
Always diluted. What about the rate?
The rate is critical too. For a patient on a regular floor, not on a cardiac monitor, the maximum infusion rate is usually 10 millimoles per hour.
10 per hour, max, unmonitored.
Right. In critical care, with continuous cardiac monitoring, they might go up to 20 millimole per hour, sometimes even faster in emergencies, but that's very specialized. Always use an infusion pump, never gravity drip.
Okay. What about treating the opposite, severe hyperkalemia?
Yeah.
You need to get that level down fast.
Yeah. For emergencies, we use things that shift potassium into the cells quickly to protect the heart. For V sodium bicarbonate, calcium gluconate to stabilize the heart muscle membrane, or a combination of IV dextrose and insulin.
Insulin drives potassium into cells.
Yep. Insulin pulls glucose into cells and potassium follows along. But these are temporary fixes to actually remove the excess potassium from the body.
That's where kayexalate comes in. Sodium polystyrene sulfonate.
Exactly. Kayexalate is a resin you take orally or rectally. It basically traps potassium ions in the gut and exchanges them for sodium ions so the potassium gets excreted in the stool.
But I remember reading a warning about that one.
Oh.
Something about the gut.
Yes, a very serious one. There's a significant risk of intestinal necrosis, basically tissue death in the bowel, especially when kayexalate is given with sorbitol, which used to be common practice to prevent constipation. Now, using it with sorbitol is strongly discouraged due to that risk.
Wow, so even the treatment has major risks. High alert indeed. Okay, let's move to the other major player, sodium, Na plus est.
Sodium, the main extracellular cation, lives mostly outside the cells. Its normal range is wider, 135 to 145 millimoles per liter.
That's a job.
Primarily water balance and distribution. It's the main driver of osmotic pressure in the ECF. Also involved in nerve impulses and acid-base balance.
So low sodium hyponatremia, below 135. What causes that?
Can be from actual sodium loss, excessive sweating, vomiting, diarrhea, diuretic use. Or it can be from dilution drinking excessive plain water, or conditions like SIADH, where the body holds on to too much water.
And the symptoms?
Lethargy, headache, confusion, nausea, vomiting. If it's severe or drops quickly, you can get seizures, coma. It's mainly neurological symptoms because brain cells are sensitive to swelling.
Okay. And high sodium, hypernatremia, above 145.
Usually related to water deficit, not drinking enough water, excessive water loss, like in diabetes insipidus again, or sometimes poor kidney function.
Symptoms here? More dehydration signs?
Yeah, think flushed skin, dry mucous membranes, intense thirst, restlessness, agitation. Can also see hypertension and edema if it's related to sodium gain rather than just water loss.
Now, treating severe hyponatremia sometimes involves that strong hypertonic saline, 3% ACL. You mentioned risks earlier.
Yes, and this is probably one of the most critical warnings in the entire chapter regarding electrolyte correction, giving hypertonic saline too quickly.
What happens?
You risk causing central pontine myelinolysis or osmotic demyelination syndrome. By pulling water out of brain cells too rapidly, you can cause irreversible damage to the myelin sheath, particularly in the pons area of the brainstem.
Irreversible brainstem damage. That sounds terrifying.
It is. The correction of chronic hyponatremia must be done incredibly slowly and carefully, with frequent monitoring of sodium levels.
Okay, slow is key for severe hyponatremia correction. The text also mentions a newer drug for some types of hyponatremia, tolvaptan.
Right, tolvaptan. It's in a class called vaptans. It's specifically for hospitalized patients who have euvolemic hyponatremia, meaning their total body fluid volume is normal, but their sodium is low, often seen in SIADH.
Euvolemic hyponatremia. How does tolvaptan work? You said it's an antagonist.
Yeah, it blocks the receptors for antidiuretic hormone, ADH, specifically the V2 receptors in the kidney.
So it stops ADH from working.
Pretty much. ADH normally tells the kidneys to reabsorb water. By blocking it, tolvaptan causes the kidneys to excrete free water without excreting sodium. It's called aquaresis.
Ah, so it gets rid of the excess water, letting the sodium concentration rise naturally. Clever.
It's a more targeted approach for that specific type of hyponatremia.
Okay, this all brings us squarely to the nursing process. Assessment, implementation, safety checks. The nurse is really the gatekeeper here.
Absolutely. Assessment is paramount. You're constantly evaluating fluid status. Checking skin turgor, pinching the skin, maybe over the sternum, clavicle, or forehead. How quickly does it snap back?
What's normal versus bad?
Instant rebound is normal. If it stays tented for more than a couple of seconds, that indicates pretty severe dehydration. You're also checking mucous membranes, urine output, vital signs, daily weights.
Listening to lung sounds for crackles, checking for edema.
Exactly. And specifically for potassium, you're watching for those early signs of hypokalemia, the muscle weakness, the lethargy, anorexia, and you have to check the patient's medication list for interactions like those ACE inhibitors or potassium-sparing diuretics that raise potassium level.
When it comes to implementation, we talked about the rules for IV potassium dilution, pump, rate limits. What about just general IV site care?
Crucial. You need to assess that IV site frequently. Look for signs of infiltration, the fluid leaking into the tissue. That looks like swelling, coolness around the site, maybe pain, slowed infusion rate, no blood return.
Versus phlebitis.
Right. Thrombophlebitis is inflammation of the vein. That'll be redness, warmth, tenderness along the vein path, maybe a palpable cord. If either happens, stop the infusion, remove the IV, restart elsewhere.
And for blood products, we mentioned saline only. What else?
The double check. 2 licensed nurses must verify the patient identity and the blood product details right at the bedside before starting the infusion. Compatibility check is vital.
And monitoring during the transfusion.
Continuous monitoring, especially for the first 15 minutes. Watch closely for any signs of a transfusion reaction. Fever usually defined as a rise of 1 degree Celsius or more, chills, shortness of breath, low back pain, itching, rash. Stop immediately if you suspect a reaction.
Okay. And those hypertonic solutions, like 3% saline. Special precautions.
Definitely. Because they can cause volume overload and are irritating to veins, they should ideally be given through a central line or a large bore peripheral IV. And because of the risks we talked about, like CPM, the patient needs very close monitoring, often in an ICU setting, including frequent neurochecks and lab draws.
Makes sense. Finally, evaluation. How do we know if our fluid and electrolyte therapy is working?
You look for improvement. Are the vital signs normalizing? Is the urine output adequate? Are the lab values, sodium, potassium, hemoglobin, hematocrit, moving towards the normal range? Does the patient report feeling better, having more energy? Can they tolerate activity better?
And equally important, are we watching for adverse effects?
Always, especially signs of fluid overload. Listen to those lungs for crackles. Look for JVD, jugular vein distension. Check for worsening edema, shortness of breath. You're constantly reassessing the balance.
Okay, so wrapping this all up, it's a complex balancing act.
It really is.
Yeah.
The key takeaways. Know your fluids, crystalloids for general hydration, colloids for specific volume expansion when needed, blood products for oxygen and major loss. And be incredibly vigilant with potassium administration rates and hypertonic saline correction speed. Those are where the biggest immediate dangers lie.
We've spent all this time talking about medical interventions, the fluids we give. But it makes you think. The body works so hard, constantly, to maintain that euvolemia, that perfect balance. How easily could factors outside the hospital, maybe just a bad stomach bug, or working outside on a really hot day, or even just a poor diet, tip someone over the edge from balanced into a critical electrolyte imbalance or dehydration state?
That's a really great point. It underscores how fundamental this balance is and how seemingly small things can disrupt it quite profoundly. It really is basic life support, understanding and managing this.
It really is. Well, thank you for walking us through this incredibly important chapter.
My pleasure. Hope this helps clarify things for everyone listening.
We certainly hope this deep dive gave you the structure and the key points you need to feel more confident with fluids and electrolytes. Thanks for joining us, and we'll catch you next time.